Okay, so now we're going to move on to the rapid podium presentations. So can I please ask, first of all, Sarah Belknap to come up. And I'm actually going to get everybody to come up, but and I'm going to read the bios right now. So Sarah's going to talk about a policy brief, traumatic brain injury and homelessness. And Sarah's completing a BA in psychology at York with a specialization in neuropsychology. She has extensive experience collaborating in healthcare settings through volunteer work with the Canadian Concussion Centre in Casey House. And with a desire to pursue social work, she continues to practice community engagement through York University's Centre for Sexual Violence and local organizations such as Pride Toronto. And can I please ask Julia Taylor, who's going to present on a virtual competency-based curriculum on concussion for primary care residents, exploring peer learner residents' feedback and impacts on self-efficacy. And Julia is a second-year med student at U of T. She is actively engaged in resident medical education for concussion care under supervision of Dr. Alice Cam, and is passionate about the fields of family medicine and emergency medicine. And Julie Osbelt, you can come on. She is going to be presenting on concussion care continuum, mapping publicly funded care pathways within the Toronto Region Health Team. And Julie's role as the Toronto ABI System Navigator is largely intertwined in her role as the ABI Referral Coordinator with the Toronto ABI Network. She's worked in the field of brain injury for over 25 years. Over the past 12, she's managed a centralized referral system for inpatient and community-based referrals across GTA. By providing a single point of entry to community-based ABI services, she assists in simplifying the process for accessing services. Julie values the opportunity to provide comprehensive navigation support to service providers, families, and persons with lived experience to find the right pathway to access programs, publicly funded ones. And then Keely Barnes, investigation of virtual concussion assessment, a feasibility study. Keely's a PhD candidate at University of Ottawa under the supervision of Dr. Sean Marshall and Dr. Heidi Sveistrup. Keely's clinical experience as a registered kinesiologist led her to pursue a PhD on virtual concussion assessments. She's been working throughout her PhD as a clinical research assistant at Ottawa Hospital Research Institute, where she's involved with a multi-center rehab trial for adults going for surgery. She's also completing the EPIC at fellowship through AgeWell during this final year of her PhD, where she's being mentored and completing additional training. And then Bianca Perry is going to be presenting Beyond the Fog, Exploring Processing Speed, Concentration, and Cognitive Functioning in Early Concussion Recovery, Findings from the Toronto Concussion Study. Bianca is a fourth-year psych student at Toronto Metropolitan University, completing a research practicum at Hull Ellis at Toronto Rehab. She's minoring in biology, and that developed her interest in neuroscience and brain physiology. And through her educational and research opportunity background, she has developed a strong understanding of brain injuries, especially concussive mechanisms. As a student athlete, she values the importance of concussion education and has welcomed the opportunity to pursue this concussion research. Jeffrey Brooks. Oh, there you go. There, okay. Compression apparel reduces head impact magnitudes in Canadian football athletes. Jeffrey is a postdoctoral fellow in the Impact Biomechanics and Concussion Lab at Western University, examining effects of repetitive head impacts and concussion in sport on brain structure and function. This work is interdisciplinary, spanning anatomy, biomechanics, neuroscience, mechanical engineering, machine learning, and big data. Dr. Brooks' research aims to prevent injury and improve sport performance through athlete head impact exposure monitoring and to provide quantitative data to makers, coaches, and trainers to make evidence-informed decisions. And lastly, Shelley Weisberg And you, BrainBot, an innovative mHealth app for concussion, self-management, and occupational performance in adults, a mixed methods study investigating usability. And Shelley is an occupational therapist with over 10 years of experience in treating traumatic brain injuries. She's also the co-founder of BrainBot. She has specialized training in concussion management and cognitive rehabilitation. Having suffered persistent concussion symptoms herself, she deeply understands their complex challenges in daily life. Shelley co-founded BrainBot, a digital concussion recovery assistant that uses data and AI to help clients manage their symptom triggers and activities. Her unique blend of clinical expertise, personal experience, and passion for technology distinguishes her in the intersection of AI and occupational therapy. Okay, so starting with Sarah's, I'm going to leave you all to it.
Thanks so much. Homelessness is a deepening crisis that Canadians continue to face daily. Myself and Dr. Maxwell Baranti have developed a federal policy brief with 3 primary objectives. First, to identify concussion and traumatic brain injury and its related psychopathology as significant contributing factors to homelessness. Second, to identify the most effective point of intervention in order to reduce homelessness among survivors. And third, to formulate actionable and realistic federal policy suggestions. A literature review and analysis was conducted in addition to an informal interview with the Minister of Mental Health and Addictions Canada. Results indicate that over 50% of Canada's population are TBI survivors, with 70% having acquired the injury prior to homelessness. The mean age of injury was found to be around 17 years old, with TBI and concussion-related psychopathology occurring in 40% of hospitalized youth. We suggest that the federal government take a youth-focused perspective on concussion and TBI interventions with the following 2 policy suggestions. First, we suggest developing national guidelines from UHN's prescribed housing model. This not only has the potential to relieve emergency room burden across provinces, as these injuries represent half of all youth injuries, but it will also reduce acute and long-term homelessness risk through addressing the social determinants of health. Second, we suggest integrating mental health into Canada's universal healthcare model. Doing so can address psychological and behavioral mechanisms of concussion and TBI that are associated with increased homelessness risk in youth. Clinical interventions have shown to be effective in treating these issues, and accessing them is crucial. In conclusion, implementing these types of suggestions will not only strengthen Canada's social values, but foster a collective effort to reduce homelessness, increase positive health outcomes for survivors, and protect Canadian youth. Thank you.
Thank you for having me here today to present on feedback we received and the impact we saw on self-efficacy for a virtual concussion curriculum. So we know that concussions are the most common traumatic brain injury in Canada, and it's essential for family doctors to be able to manage this condition. However, a survey of University of Toronto family medicine residents found that 12% reported receiving no training, and a third believing it was unnecessary for patients to see a family doctor for concussion care. A previous study of our curriculum found it significantly improved knowledge related to concussion management amongst University of Toronto family medicine residents. This follow-up project wanted to elicit feedback on the virtual curriculum and to evaluate its effects on our peer learners' confidence in managing concussion symptoms. The curriculum was administered to 120 residents from July 2021 to June 2022. Through a spiral integrated design, we delivered an electronic self-study guide, a virtual academic half day, which was led by peer teacher residents, and had participation in a concussion clinic for the residents. These were designed to build on each other and reinforce resident learning. Our present study will look specifically at those first 2 virtual components, and we distributed feedback surveys by email after. We had a 20% participation rate in our survey and found that mean self-rated confidence, clicked back, mean self-rated confidence improved significantly amongst our respondents. In terms of feedback, we saw that curriculum enablers were peer teacher to peer learner interactivity, as well as contextualized learning through case-based teaching methods. Some content that remained challenging still for residents was return to activity guidelines, as well as any medication use for symptom management. In conclusion, we found that this follow-up study demonstrated our virtual curriculum was effective in increasing resident confidence in concussion management. A virtual format that's enriched by learner interactivity and case-based teaching method could be applied to provide education as well in more distant communities. In the future, we hope to include interdisciplinary team members and consensus surveys on our project. And thank you.
Hello, everyone. Okay, so today I'm going to speak about the Toronto Concussion Navigator tool. Judy alluded to this a little bit earlier. And our talk is about mapping publicly funded care pathways in Toronto. So there are many clinics and resources to support individuals with concussions, but there's no tool to find and access concussion care in this region, as well as many other regions. And as a system navigator, I see this weekly in calls that I receive from concussion patients. As part of the Neurotrauma Care Pathways pilot project, we aim to create a practical navigation tool for patients, their caregivers, and health practitioners to use and find access publicly funded specialized care, concussion care in the Toronto region. That was our target area. It was the Toronto region for now. So we did an extensive online search. We found 13 concussion clinics in Toronto. We interviewed each of them. The guidelines were OHIP funded and doctor physician led. We mapped those concussion clinics throughout Toronto. We had a prototype development, which included involvement from our 6-member lived experience committee. They helped us make sure the tool was going to be user-friendly and accessible. We did go through revisions and iterations, and we were able to launch the tool on February 29th. It's a very, very new tool. The landing page, if you were to go to the tool, it's very easy to use. The idea is that individuals need to have a diagnosed concussion. There are 4 simple questions that they need. They're non-identifiable: date of injury, how you occurred your injury, age, and your postal code. And then each clinic that's found within the tool will provide an OHIP-funded consultation at no cost and no obligation to pay out of pocket. Services may be provided by a doctor, including neurologists, physiatrists, sports medicine specialists, and nurse practitioners. This is just an example of what would come out at the end after answering the questions. So you can see that first 2 clinics have links to describe the clinics. They have more details about the clinics, and this is a printable copy that could be shared with the individual and taken with them to their physician in order to possibly get connected. There's also more information on how to get the referral forms, details about which providers are involved, wait times, as well as location of where the clinic might be. Wait times was really important for our lived experience committee. We're very excited that the tool just launched, and we're hoping that you notice we have our postcards on the tables. And we really think it's important for individuals to get connected. And so if you feel passionate like we do, the postcards are available here, or we do have our QR code here. And I know that my time is running out, but I did want to say so far, we've had 124 individuals complete the tool, so service providers and or persons with lived experience. And the average age is about 42.2 years of age, and most of them are 2.5 months post-injury. We would like to say that currently we're just in Toronto, but we're looking to expand to the province of Ontario. Of course, if we secure some funding. And again, if you can, we would love to promote to get people in the right place at the right time. Thank you very much.
Hey, hi everyone. Today I'm going to be presenting a feasibility study where we investigated a virtual physical concussion assessment. My acknowledgements are presented on the slide here. Starting off with some background information. With the shift in clinical service delivery to virtual healthcare, driven by the COVID-19 pandemic, the need for valid and reliable approaches to virtual concussion assessments has become more pressing. And we begin to explore this issue with this feasibility study, where objectives were to determine rate of recruitment, length of time required to complete our study procedures, determine subjective acceptability and confidence on findings on both the in-person and virtual assessment, and document preliminary information on sensitivity and reliability of the virtual assessment. In order to achieve these objectives, we had patient participants, which included both people with concussion along with other forms of acquired brain injury, attend an in-person and virtual assessment, which was completed by one of our clinician assessors. We recorded the virtual assessment so that it could be viewed by a different clinician at a later time independently. The measures included in our virtual assessment are presented in the table on the top right here, and the methodological process for the assessments is presented in the figure below. In terms of results, so feasibility results, we were able to recruit on average 1 patient participant per week. We recruited a total of 20 patient participants and 3 clinician assessors. Our virtual assessment took a bit longer, 13 minutes compared to our in-person 9 minutes on average. We experienced some minor technical issues. In terms of feedback, most of our participants believed that similar findings were obtained on the 2 assessment approaches. The patient participants had some feedback regarding challenges communicating over a screen, some feedback regarding lighting, screen size, as well as visibility of their clinician demonstrating measures. The key clinician participant feedback was that patient participants were fatiguing during the second study assessment. The table on the right here presents some preliminary information on the psychometric properties. Our sample size was only 20, so this is not adequately powered to establish these properties, but this is what the preliminary data suggests. So properties vary from moderate to strong for both reliability and sensitivity. So to conclude, the feasibility study indicates that components of our virtual physical concussion assessment are both feasible and acceptable to people living with acquired brain injuries as well as clinicians. And we are currently recruiting 60 participants in order to document those specific psychometric properties associated with the virtual administration of the concussion measures I presented. Thank you.
Good afternoon, everyone. My name is Bianca Perry, and I'll be presenting on behalf of the Hull Ellis team. Oh, my bad. Okay. So without baseline testing, post-concussion cognition in patients is typically evaluated using neurocognitive tests, and performance is measured against normative data. And the objective of this project was to examine the relationship between cognitive symptoms, including fogginess and concentration difficulties, and the corresponding performance on neurocognitive testing within 2 weeks post-concussion. Adult participants were recruited prospectively from the Hull Ellis Concussion Clinic within 1 week of injury. The C.E.T.S symptom inventory was administered for self-reported symptoms, and processing speed measured cognitive clarity through symbol search and coding tests, while trails A and B measured for concentration. Our population of adults had an average age of 33 years, who were well educated and 59.9% female, and the most common comorbidities were anxiety and depression. Individuals completed the measures at weeks 1, 2, and 12, and by looking at these box plots, we can see that as people report more significant fogginess and concentration difficulties, their performance worsens on corresponding tests, and we can see that mostly in severe reported symptoms. However, these individuals still fell into low average to average ranges according to traditional normative data. And at weeks 2 and 12, no association was found between self-reported cognitive symptoms and neurocognitive test performance. While subjective symptoms and objective performance were aligned within 1 week of concussion, it was found that using published norms to quantify cognitive difficulties may yield false negative results. Therefore, our sample suggests that population-specific normative data are needed to accurately evaluate cognitive performance in post-concussion patients. Thank you very much.
Hello, everyone. I'm going to take a little different spin on things, talk to you a bit about potential for injury prevention. So looking specifically within the sport of football, but it is applicable to other sports and even military domains. But what we did was a lot of previous research has looked at within the sport of football on switching up the design of a helmet to try to lower head impact magnitudes in a opportunity to try to make the game safer for players. But there are only so much you can do to the helmet to prevent or try to prevent injury. And particularly, there's been a focus on putting a soft shell cap, which you can see in the bottom photo there, over the helmets, which is supposed to mitigate the forces during a collision. However, a few studies that have examined the use of these caps has shown that they don't actually do that. They don't really change the head impact magnitudes. So what we did was looked at a slightly different type of equipment. So this is a collar that is attached to a compression shirt that can be worn by, in this case, the football athletes. And the collar is made of a viscoelastic foam that will stiffen upon acceleration. So it acts kind of like an airbag almost for the neck, where it will slow acceleration of the head and neck down. And what we did was what we used was helmet mounted sensors in the football helmets to measure head impact, linear acceleration and rotational velocity of head impacts. And the players wore the collars in the second half of the playing season. And then we matched head impact of the same player with and without the collars. And big results were that the collar did in fact reduce head impact magnitudes. It reduced the linear acceleration of impacts by about 13 Gs, and it reduced the rotational velocity by about 200 degrees per second on average. And so this is kind of interesting new or different take on equipment and how it can be used to potentially lower injury thresholds. Thank you.
Hi, everyone. So thrilled to be here. Thanks for having me. My name is Shelley Weisberg. I'm a co-founder and chief clinical officer of BrainBot. As an occupational therapist with over a decade of experience in concussion rehab and a personal 8-month recovery journey, we created BrainBot so that no one feels as alone or frustrated as I did during my recovery. So this study was BrainBot's first research project, which was looking at the usability of the pilot version of BrainBot's mobile app. So by way of background, the first evolution of BrainBot is a digital app that enables users to manage their symptom triggers and that helps them return to activity. So it starts with a quick assessment to establish a user's baseline or a daily point goal. And using data and insights from logged activities and symptoms, these point goals are then personalized and adjusted each week. So we had 20 participants with persistent post-concussion symptoms who were given the opportunity to use BrainBot over 28 days. So the first evolution of BrainBot's mobile app scored 69.6 on the modified system usability scale, which is slightly above the standard benchmark of 68. So this indicates average usability and good acceptability. And we're also really excited that 75% of the participants used BrainBot for an average of 6 days, 6 out of 7 days per week over the 28-day period. So overall, BrainBot's usability score and high level of engagement underscores its potential as a promising self-management solution for concussion recovery. The limitations of our study, including a low and predominantly female sample size, which I see as a trend, they are acknowledged, and so future research will focus on a broader demographic to validate these findings. Based on the results from the study, we have enhanced BrainBot with new features, including offering personalized insights and guidance to both patients and their clinicians so that we can improve care with targeted data-driven strategies. So for instance, in situations where somebody has overstimulation from being at the grocery store, BrainBot now suggests personalized and actionable strategies like going during non-peak hours or wearing noise-canceling headphones so that they can still do the activity, but managing their symptoms. So we're really excited to continue our research for the ongoing development and to evaluate the efficacy of the tool. Thank you.
Very much to all of the presenters. Those were great, really interesting. So we don't have any questions on the chat for you. So for those of us that are here, can you please, if you have questions, can you connect with the presenters over the refreshment break, which we have now? And can I ask everyone to come back at 3:35, please?